Hi, this is Professor Rich RN. I'm going to go ahead and present to you guys a DKA or Diabetic Ketoacidosis lecture today for NCLEX review or just general knowledge. I'd ask you if you're liking the videos and liking the channel, please go ahead and like and subscribe, and I continue to produce more content. So DKA. Primarily, you're going to see this in type 1 diabetes. It's going to be very rare for those people that have type 2. You're definitely going to see the ketones, which are the fatty acids being broken down. That's going to be a byproduct, and that's going to result in acidosis, right? And that's how you get the diabetic acidosis, okay? It's going to result in having an acidosis, so pH is going to be less than 7.35. There's going to be extremely high blood sugar, and it's going to be a sudden onset, which often is a result of infection or stress. One of the other major signs that you're going to see with this is Q-small breathing, which is deep, long, rapid breath, trying to blow off all that acid, and you're going to get fruity smelling breaths from that acetone. So again, the causes are typically an illness or infection. It also can be caused by insulin therapy non-adherence, right? So if someone is not taking their insulin as prescribed, of course, that can result in hyperglycemia and then continue to go high and result in DKA. The stress relations can be, of course, the physical or emotional traumas, heart attacks, strokes, pancreatitis, pregnancy, alcohol, drug abuse, and certain medications like corticosteroids and diuretics can also lead to DKA. All right, so your symptoms of DKA, what to kind of look for. So of course, they're gonna have high blood sugar. That's kind of what we're looking for. Hypoglycemia is gonna definitely be present. You're gonna have ketones that are gonna be present in the urine, and they're gonna have that fruity scented breath. They're also gonna have hyperkalemia, right? So the fluid shift there, because of the osmotic pressure and concentration gradient, you're going to have potassium leave the cells and go into the bloodstream. So they're going to present with hyperkalemia. They're going to have excessive thirst, again, because of that fluid shift from the cells. The water's leaving the cells, going into the blood, and then it's going to be excreted out through the kidney. So they're going to have that excessive thirst as the body's trying to replace that fluid. You're going to have that frequent urination, polyuria. That is because we're getting rid of all that fluid that is leaving the cells into the bloodstream. They can present with nausea, vomiting, weakness or fatigue, shortness of breath, and they can also be confused, so altered level of consciousness, depending on how advanced the DKA is when they present themselves for treatment. For initial care, what are we going to do, right? So as mentioned, the water is leaving the cells into the blood because of the concentration gradient, the osmotic pressure concentration there. So that fluid gets released through the kidneys, causing polyuria and therefore dehydrating the patient. Okay, so we're going to want to treat that with fluids. And then as mentioned, hyperkalemia is a big deal, right? And so our normal range is 3.6 to 5.2, depending on where you're looking, millimoles per liter. Here, again, the potassium is leaving the cells, going into the blood, right? And that's a big deal because it can cause life-threatening arrhythmias if the potassium level is too high. So we want to eventually get that potassium back into the cells, increase BUN and creatinine. That fluid shift is going to cause that dehydration and potential a kidney injury because of that fluid. Again, as mentioned, it can cause confusion, so we want to monitor for altered level of consciousness, again, which can result to that fluid shift. So the goals, right? Of course, we want to reduce that acidosis that is formed because of the ketones. We want to correct that hyperkalemia. We want to lower the blood glucose and improve the fluid balance. Those are our main goals when we start treating the patient. So we're going to give them insulin, right? Insulin is going to help them reduce that blood glucose by bringing that glucose into the cells. It's also going to correct the hyperkalemia. It's going to ask the potassium to move from the blood, and it's going to carry it also into the cells. So it's going to collect that as well. We're also going to replace the fluid with, improve the fluid balance by giving them fluids. As we're doing that though, as a very good nurse, we're going to go ahead and watch out for some major complications that can occur. Okay, so as I said in the last little part there, we're going to give them insulin. That's going to be in the IV form. It's going to be done through regular insulin through the IV. Okay, and so we're going to have to continuously check their blood glucose, and we're going to titrate that up and down, that drip, depending on how their body is responding to the insulin and how their blood glucose is reacting. So if we do it too fast, of course, they can have a hyperglycemic episode. If we're giving them that insulin, the glucose is going to fall, the insulin's going to take that glucose and it's going to move it into the cells. So we got to watch out for hyperglycemia. I said one of the complications of initially when they present is hyperkalemia, because the potassium has left the cells and gone into the blood sugar, okay, because of the fluid shift. Well, now that insulin is going to take that potassium and put it back into the cells. If it's too fast or too much, it's going to result in the patient becoming hyperkalemic, which can impair, again, the heart, right? So we got to watch for that as well. So a lot of labs are going to be involved with this and a lot of constant checking and monitoring. We're going to also be giving them fluid. Correct that dehydration, we can cause swelling in the brain or cerebral edema. So we got to monitor the fluid that we're giving them, and we got to assess their ALC and make sure that we're not giving their fluid too much. Okay, that's another consideration. DKA, I would ask you to go ahead and like and subscribe to the channel. And if you would like more information, please watch the other diabetes NCLEX review. And there's also going to be the HHS video as well. So please go ahead and watch those as you prepare to take your NCLEX.